Just going to give it a few minutes as guests are coming in, and then we'll get started shortly. All right, we're going to go on ahead and get started. Again, welcome to the Million Hearts Hypertension and Pregnancy Action Forum. My name is Taylor Streeter. I'm a health scientist with the Million Hearts team, and we're just going to get us started today. So first, I'm going to go through a few logistics. We are so pleased to have so many representatives and organizations from around the country. If your affiliation is not at the end of your name, at this time, could you please right-click and select Rename? We would love to see where you all are from. Please also unmute yourselves when we take the time for questions and updates. We would love to hear from you all. And also a friendly reminder to please keep yourself on mute when not speaking. Your microphone icon should have a red slash mark through it. And we have the chat box available for your questions and comments, so please place those there. This is another reminder that this meeting is being recorded. If you object, please leave this meeting at this time. And lastly, we will have an opportunity to participate in a few polls. These polls are confidential but not anonymous, and we'll tell you more about that when we launch our first poll. Next slide, please. And now it is my extreme pleasure to introduce our moderator, Sue Kindig. Sue is the Director of WHNP Practice and Policy for the National Association of Nurse Practitioners in Women's Health, and she's also a Women's Health Integration Specialist. The CDC and Million Hearts team has had the great pleasure of working with Sue. She is a co-author of our Hypertension and Pregnancy Change Package, which we'll hear more about during this call today. So without further ado, I'll turn it over to Sue.
I listened to the instructions and forgot to unmute. Hi, everybody. Thanks so much, Taylor, for the introduction. As Taylor said, I'm Sue Kindig. I'm a women's health nurse practitioner as well as an attorney, and I've been fortunate to work with the CDC on the change package, but have been involved in multiple projects at the national level and interventions at the national level, working with the Alliance on Innovation in Maternal Health, the Alliance on Innovation in Maternal Health Community Care Initiative, the Women's Preventive Services Initiative, and multiple other national initiatives that are really highlighting issues around cardiovascular disease and its impact on birthing people, not only during pregnancy and the postpartum period, but the implications, the long-term implications. And that's really why we're all here. So I also should say that I'm based in St. Louis, working with a large health system in the St. Louis area, as well as some state initiatives similar to the national initiatives I mentioned. We are thrilled to have over 350 people registered for this event, because we know that the health of birthing people, pregnant and postpartum people, and women's health across the lifespan is really a team sport. And you all have shown up here. That really shows your commitment to that collaborative effort. I was so pleased to see we have multiple health departments. As an old public health nurse, you know, I am so pleased to see so many of our health departments. I can't name them all, but we have health departments from across the state or from across the country who are really looking at this. And health departments are true leaders in mobilizing efforts in their states and helping with that data collection and so forth. We have academic medical centers. We have every type, every discipline of healthcare provider who is touching birthing people and people throughout their lifespans. We have primary care associations, and we're going to see how important their work is, particularly in those transitions of care. So we are just so thankful that all of you are here. What we are really wanting to do is address hypertension in pregnancy through implementing evidence-informed strategies. And you all know that, again, there are many initiatives that have already started around hypertension in pregnancy. A lot of those are hospital-centric. And what this effort aims to do is also look at what happens outside those hospital walls. So really looking at that continuum of care, not only during pregnancy and postpartum, but again, those long-term implications. And so there are opportunities for everyone, for clinical, for our public health, community-based partners, and so forth, to really step up to the plate, lead in efforts in their state, in their communities, in their organizations, collaborate with partners, make new friends, people and entities that you've never partnered with before. Because again, this is a team sport, and we need all hands on deck to really address this important issue for maternal and women's health. Toward the end of the call, because we know that the CDC efforts, the Million Hearts efforts, and the Hypertension Change Package aren't the first initiative around this. We know that you are all doing fabulous work, and our goal is really to support that work, highlight that work, and share that work. So toward the end of the call, we're going to ask you to place in the chat any links to upcoming events related to hypertension and pregnancy that you might be organizing or aware of. So kind of think on that as we're going through the presentations. Next slide, please. But right now, we're going to launch a poll, and we'd like to know which of the following interventions you're currently implementing. And as Taylor mentioned earlier, this is not an anonymous poll, but it is confidential, meaning that we will not be sharing your name when we share the summary, the aggregate information around the polling, but we will have that information because that's giving us some information about who's doing what, the experts that we may not have tapped or known about, and so forth. So that's why we're doing it that way. If you can take a minute to submit your answer, I only see one person answered. So let's just take a few seconds and Taylor, how are we doing on the poll?
We're good. They're still coming in. So far, we
Okay.
have about half of people participating, about 50%. So keep the answers coming in, and then in a few
I'm
seconds, we'll
seeing
share.
I'm seeing somebody saying they're not clinical and there was no option to opt out of the poll. Um, I'm going to make a suggestion, and Taylor, you help me out if this isn't helpful. But if you're not clinical, but your organization is working on something, would we not want to know that also?
Absolutely.
Okay.
Absolutely. Okay.
And I'm just seeing some comments. We're a state health department. We encourage and support, but don't implement. There may be differences in other areas. Okay. Okay, are we ready to share?
Mhm. So I will
Oh, I love
share the
it.
results.
Pennsylvania has a learning collaborative for health centers using self-monitored blood pressure. We need to capture that. That's wonderful. Pennsylvania is my home state, so I'm very proud of you. Okay, let's look at the summary results. Well, it looks like leading the efforts is the use of self-measured blood pressure on remote patient blood pressures, as well as accurate blood pressure measurement. So two really big issues that the change package addresses. You may find resources there that might be helpful, and certainly let us know if you have things to add. Also, early identification of chronic hypertension, really important, again, not only for pregnancy, but that long-term implications, as well as postpartum counseling. So there's a really good spread of work that is already being done around hypertension in pregnancy. Thank you. Can we move to the next slide? Okay. It is my pleasure to turn the call over to Dr. Janet Wright, the Division Director for the Division of Heart Disease and Stroke Prevention at CDC, and she's going to kick us off and share with us why all of this matters to the CDC. So, Dr. Wright?
Thank you so much, Sue, and thank you for your long-term investment in this important work and the work of your association, both with creation of the change package and all the clinical work that you've been doing, public health and healthcare. So I will share with you quite briefly a rolled up version of why this matters so much. And I think of it as H and P and K. So H is for harm. This is harming women and families across the country. P, this is preventable harm, and nothing gets my dander up more than not fixing a problem that we getting to the K, know how to fix. So harm, preventability, and knowing what works and getting that implemented. That's what is driving me and us at CDC. Those are sort of facts, but from my heart, I bring several lenses to this work. And the first is a woman. I've said to many of you that I've cared about women's health and women's cardiovascular health since there was a battle going on between the size of my hair and the size of my shoulder pads. So that goes back. And I have become over time a mother and now a grandmother. And the opportunity to prevent harm for women across the country and women in all the roles that they play is incredibly motivating to me. I know the roles that women play in their families, in their communities, in their workplaces, and the devastation that occurs if a woman is pulled out of all of those connections. Secondly, as a doctor, practiced cardiology for a long time, and I will tell from the whole 23 years, some of the most vivid memories I have are a phone call from an OBGYN colleague where a woman was in distress, which of course meant the baby was also in distress. And nothing was more panicky for me than to walk into that setting. But the second most memorable, the memory that I have from those occasions were the teams that were at work, the teams of nurses and supportive staff in maternity and labor and delivery, but also on my side with nurses and technicians and technologists in cath labs and laboratory throughout all of the teams in which healthcare thrives, by which healthcare thrives. So I'm so excited about the team aspect of addressing hypertension in pregnancy. And then finally, as a late blooming public health professional, we talk and think and work day and night focused on reach and impact. We design and convene and fund and support and focus on trying to create resources that are adaptable and adoptable by a wide variety of both clinical and public health experts across the country. And what excites me so much here is that we are fulfilling that mission with all of you. We are being of service to you. And I think this is an incredibly wise investment of taxpayer dollars, which is part of our stewardship role. So the opportunity to have a generational impact is what we're talking about today and in these forums going forward. I want to thank all of you for being here today. I personally have not experienced hypertension in pregnancy. And so now we want to show a video of Alicia Saunders, who graciously is sharing her story with us, and hope that you find it inspirational and action generating. Taylor.
My journey to motherhood started in 2017 with my daughter, Zoe, who is now 6 years old. I remember telling my mom when I was a little girl that I wanted to have a little girl. Fortunately for me, that dream was able to come true with my firstborn daughter, Zoe. In June of 2020, at 36 weeks, I found out that my daughter didn't have a heartbeat, literally at the 36-week appointment. And the next day, had to deliver her, and within 2 days, I was home. So of course, at that time, my world was consumed with the fact that I just lost a child. Within 7 days of me going back just for routine follow-up visit after delivering my daughter is when my provider discovered that my blood pressure was steadily climbing. It was like 150 over something, but it was extremely high. And so they continued with the visit, and they said they would check me again before I left. And when they checked it, it was actually even more elevated. And so at that point is when they said, no, you're not going home, you're going to the emergency room because we believe that you are dealing with postpartum preeclampsia. I'm forever grateful for them because I'm glad that I had a healthcare team that was that invested in me and not just something that they would turn their heads to, or you just had a baby and you'll be okay. I'm glad that they recognize what this could potentially be and monitored it even while I was there in that visit and thought enough to say, no, you need to go to the emergency room. If I have the chance to share my story and talk to other women, I tell them if you feel something or something doesn't seem right, definitely communicate to your provider about that, because it can be literally a matter of life or death for you or your unborn child or born child. When I got pregnant with my son, in anticipation of me developing preeclampsia, I had to do remote monitoring. So I had to check my blood pressure in the morning, midday, and again in the evening. And I did that throughout the course of my pregnancy. The remote monitoring, that's just amazing that that's something that you're able to do. Oftentimes, you'll be nervous to check. It's like, oh Lord, because they're going to see it. It's going to be in your chart and they're going to see it. But I'm just grateful for that because I don't have to be in a doctor's office or they didn't have to be in my home, but I was still being monitored from a distance. And another thing that I loved about my healthcare team, if they did see an elevated number, I was getting a phone call. And if it was too egregious or if the pattern was not what they wanted to see, I was being told to come in. Be active in your healthcare, be active in this journey, be an advocate for your own health and an advocate for your own unborn child. And even after this child is born, you gotta be an advocate for yourself. Thank you, thank you, thank you for being so committed to your job, and it not just being a job for you, but being concerned about me as a person, being concerned about my unborn child, and being dedicated that I received a positive outcome. Some outcomes you can't control, but you're doing everything within your power to ensure that I had a positive experience and that me and my unborn child, and not just for my healthcare team, but for all healthcare providers out there that are demonstrating this level of care for their patients. It just means so much to us, and it's something that we will never forget.
Thank you so much for that video. That was so powerful. And now we want to hear from you all. Now that you've heard these examples, we want to hear from you as to why is this work important to you? Why are you engaging in this work? And you can raise your hand or chat it in, but we'd love to have some discussion to hear what motivates you. And I don't know if Alicia is on the call, but Alicia, thank you so much for sharing your story. The video is amazing and so powerful.
Alicia is on the call if she
Thank you
wanted
so much for having me.
Well, we're thrilled to have you, and that was just such a powerful story. Thank you so much. Now, I'm seeing a few hands up, and I'm going to have to ask the folks with CDC to kind of help with the hands. I'm seeing Megan O'Brien. Megan, do you want to share why this is important to you?
Thank you so much. My name is Megan O'Brien, and I am a clinical program manager for the remote blood pressure program at Boston Medical Center. And I just wanted to first thank Alicia for that amazing story and for sharing that experience. My role at BMC is actually to be one of the nurses that would call somebody who has high blood pressure. And so at BMC, we've developed a pretty robust remote blood pressure program for both antenatal and postpartum patients. And so, sort of to circle back to that why statement, I think what we've learned and why we've become so robust with our monitoring program at BMC is that, when we look at preeclampsia, it's always been recognized as this very scary, very harmful, dangerous thing, and it certainly is. But I think as we look at our severe morbidity and mortality numbers across our country, I think what we can deduce is that there are technologies and strategies and innovations that we on this call can be very responsible for and impactful with by bringing it into the healthcare systems and making better ways to treat, to manage, and to really reduce that fear piece that comes with preeclampsia. And I think that's what we've been able to do at Boston Medical Center is really to help patients understand what can happen, what to do if something happens, when to call, where to go, all of these education pieces and all of the information that we've been able to now get out to patients and to use the technologies that we now have and to create a really full circle treatment plan for patients who are at risk or experiencing hypertension in pregnancy. And every single day in my job, I'm able to tell some sort of story, about a patient and their experience and my relationship that we've been able to build together. And it's just been such a rewarding experience to recognize that we're at the forefront of creating just such a new path for this type of care. And so, again, thank you, Alicia, for sharing your story. And I'm so grateful to be able to do this work. Thank you all.
Great. I'm seeing a few other hands. Tina Yarrington.
Hi, good morning. First of all, Ms. Saunders, thank you so much for sharing your story. And I see in the chat, this story happens a lot. I'm an MFM doctor currently out at University of New Mexico and a new transplant to here. I'd stood up a remote blood pressure monitoring program in my prior practice, which was an urban inner city. And the response from patients was they felt paid attention to, which is something they deserved from the beginning, but putting the layer of you evaluate your health and I'll respect that number and act on it, I think served as a building block towards improving relationships across communities that were otherwise deeply, deeply steeped in structural racism. I came out to New Mexico because I wanted to be part of the solution for rural maternity care in a state that has high morbidity and mortality and is at least a third a maternal health care desert. And I'll acknowledge, I think one challenge in the rural areas of the United States is that there is not the same digital access. I was using cell-enabled stuff in my prior practice. And here, there's not only Wi-Fi deserts, there's no cell service on some of the reservations. And so the solution for true remote blood pressure monitoring is kind of a puzzle I'm still participating in solving with amazing people. But I do want to share that one of the Indian Health Services hospitals that I have privilege of working with in my job is already doing self-monitored blood pressure for their pregnant and postpartum population at risk. And I think it's transformative, particularly having this new experience working with Indigenous American people who experience not only structural colonialism, but higher rates of preeclampsia and higher rates of lifelong cardiovascular disease, to be able to say, I'm not going to act on the blood pressure that I just obtained in my little outreach clinic with my staff. I'm going to look at the blood pressures that you get at home that reflect your health and your true state. And we're going to act on that. Again, it builds trust and it builds self-efficacy. I can't say enough about the importance and value of self-monitored and ideally remotely obtained blood pressure to bring down some of the barriers that the majority probably of pregnant and birthing people experience in the United States.
Thank you so much. And, you brought up so many good points, particularly in terms of the access issues and the barriers in terms of even Wi-Fi and infrastructure issues that we truly don't even think about with some of our interventions that that we really need to keep top of mind as we are sort of rolling out some of these interventions because, again, I do a lot of work in rural Missouri, same issue. The next hand I'm seeing is Lisa Ollier. Lisa?
Thank you so much, Sue. It is a pleasure to be here today. Once again, I do want to thank Alicia for sharing her incredibly powerful story. I'm a medical officer on the maternal mortality prevention team in the Division of Reproductive Health, and we were so delighted to partner with the Division of Heart Disease and Stroke Prevention on the hypertension and pregnancy change package. This work is really important to me because in my role, I see far too many deaths from hypertensive disorders in pregnancy. And I know that we can prevent a significant proportion of those deaths working together with patients and families, with providers, the facilities, and the systems in which we all live, and bringing in our community partners as well. We'll continue to work to keep getting data that will drive action and make that available. And I'm just so delighted to see so many people on this call who are going to make a difference. Thank you, Sue.
Thank you. The next hand I'm seeing is Jane Ellis. Hi, Jane.
Hey, thank you all. I'm Jane Ellis. I'm an Emory maternal-fetal medicine. I practice at Grady Hospital in Atlanta, which is a large safety net hospital. And I'm a founding member of Georgia's Maternal Mortality Review Committee. And I just have to say on hypertension, it has been such an interesting thing for me to watch over the past 20 years that I have practiced. Many of my pregnant patients come from families, of course, here in the Deep South, where everybody has hypertension. Everybody takes medicine for it. Nobody worries about it because it's just something you have. So it's been a tremendous learning opportunity for me to know how to connect with patients or learn how to connect with patients so that they take their numbers seriously and that they have come to realize that it's not okay for everybody to have high blood pressure. It's a problem for you. It's a problem for your baby. It's something we can treat. It's something you can do something about. So over the past 2 years, a lot of my pregnant patients are now coming in with their blood pressure cuffs. They're really recording their numbers. They're taking their aspirin. And it's been, I think, really rewarding to see how everybody being involved in making this an issue, at least in my patients here, the message has hit home and they are taking it seriously. They're taking their own health and the health of their babies, as well as their family members who also have hypertension, seriously. And I think we're starting to see a real difference in our outcomes here. Thank you.
Thank you. I am going to take a minute to give a nursing and nurse practitioner perspective, and then I'm going to ask my CDC colleagues to maybe give me a time check, and maybe we can look at some of the comments in the chats because there are some pretty powerful statements. As I mentioned, I'm a women's health nurse practitioner, but this story is from, oh gosh, probably 30 years ago. I was working as a clinical educator at a level 3 facility in the St. Louis area. And we accepted transfers from rural areas, throughout Missouri and Illinois. And one day, one of our maternal fetal medicine specialists called me up to the medical intensive care unit. And he was just standing looking into the room of a young mom who was in her early 20s. I think she may have had a few children. It's hard to remember, but the bottom line was she had developed preeclampsia. The care had not been escalated quickly to get her to a tertiary facility. And she had DIC, her organs were shutting down, and she was dying. And he said to me, I wanted you to see this because you teach nurses, and this should never happen.
Mm.
And that has stuck with me for 30 plus years. I actually was the director of the Women's Health Nurse Practitioner Program at University of Missouri for 20 years. And because of that mentoring, because there was a physician colleague who saw that it wasn't only his responsibility, but that it really takes a team, and we all have to know this. I incorporated that in my teaching around preeclampsia throughout my entire career. And that is why I'm passionate about this, because it's the power not only of what we do as individuals or knowing the information, but it's how we share, how we mentor, and how we support one another. And I'm going to call out that mentor. It was Mike Nelson at Washington University, because I know there are MFMs on here, and some of you may know him. And I've always felt that that was one of the most impactful moments of my entire career, and really set the stage for the importance of education and mentoring. So all of that being said, part of what we're doing here is sharing and mentoring one another to keep that message going, so that less people will die or have lifelong effects from cardiovascular disease and hypertension in pregnancy. That being said, I know people have been monitoring the chat. Judy, Hillary, are you seeing any?
You know, Sue, I think I'm seeing unbelievable stories in the chat, both from clinicians who had experiences like yours that motivated them, others that have survived, quite a few that have talked about their hypertension and preeclampsia and eclampsia. I would just encourage people to read the chat. I think from a time standpoint, we can move on, but I want to thank everyone for what they're putting in the chat as to why you're here. That helps fuel us to know that this type of gathering where we can be exchanging information and tools and resources it is of value, as Janet said, potentially good use of public funds. But Sue, why don't we move on?
Okay, great. I think the next slide, we are going to have Hillary Wall, the science lead for Million Hearts, who's going to provide an overview of the hypertension and pregnancy change package. So Hillary.
Thank you so much, Sue. And this is already, like, I'm going to try to not start crying, because you all are so motivational and inspirational in everything that you've shared. So I am thrilled to have these next few minutes to talk to you about our recently launched Hypertension in Pregnancy Change Package. So if we can go to the next slide, skip through no disclosures. Next slide, there we go. Million Hearts, if you're not familiar, we have a very sort of mixed bag of folks who have joined this call today, which is wonderful. But I just want to level set. Million Hearts is a national initiative. We're co-led by CDC and the Centers for Medicare and Medicaid Services. We have an ultimate goal of preventing acute cardiovascular events. And for over a decade, Million Hearts has worked with clinicians to improve blood pressure management in non-pregnant populations. And then every 5 years, we take an opportunity to sort of refresh our platform with the newest science and opportunities to prevent acute events. And in 2022, we added a focus on pregnant and postpartum persons with hypertension, really to share the knowledge and successes that we had acquired in the previous decade. Next slide. So again, just more quick level setting, because we've got this mixed audience. Hypertension in pregnancy is defined as 2 or more blood pressure readings greater than or equal to 140/90 millimeters of mercury. If it's pre-existing, so the person comes into pregnancy already having hypertension, or if it develops in the first 20 weeks of gestation, it's considered chronic hypertension. If it develops after that 20-week gestation period, it's considered gestational hypertension. And severe hypertension is defined as 2 or more readings of greater than or equal to 160/110 millimeters of mercury. This is a serious condition that is urgently attended to. There is a wonderful existing quality improvement infrastructure to support changes to care for treating severe hypertension, including things like perinatal quality collaboratives. And I know we've got a number of members on this call from those organizations. There's also the Alliance for Innovation in Maternal Health, or AIM bundles, and Sue mentioned those. Lots of really tremendous resources. And we were not looking to recreate that wheel. But for many years, clinicians were sort of unsure of the safety and efficacy of treating mild chronic hypertension. So chronic hypertension that hasn't reached that severe threshold. So pregnant patients whose blood pressure was between 140/90 and 160/110 generally did not get treated. That is until, if we can go to the next slide, until 2022, when findings from the Chronic Hypertension and Pregnancy, or CHAP, trial were published in the New England Journal of Medicine. This was a great study and sort of like simple and elegant. I like a really well-designed study, but they randomized 2,400 pregnant women with mild chronic hypertension to the treatment group who received antihypertensives if their blood pressure was above 140/90, and the control group who received antihypertensives if their blood pressure was at that severe threshold. For the study, it was 160/105. And the study team saw an 18% reduction in risk of their primary composite outcome in the treatment group compared to the control. And I listed the components of that primary composite outcome on this slide, but it included preeclampsia with severe features, medically indicated preterm birth, and other conditions. And I also want to note that they saw a 21% reduction in risk of all preeclampsia in treatment versus the control. And so this reduction in adverse pregnancy outcomes was observed without fetal growth restriction, which was their primary safety concern. And so almost immediately, the American College of Obstetricians and Gynecologists, or ACOG, and the Society for Maternal-Fetal Medicine, or SMFM, they issued new practice guidance to their members recommending that clinicians treat mild chronic hypertension when blood pressure gets above that 140/90. And so it is this exact practice change that we are wanting to support. And I hate to share this number, but I always do. Studies have shown it can take up to 17 years, that's 17, for new scientific findings to make their way into clinical practice. But right now, everyone on this call, we have a very timely and important opportunity to ensure that this timeline gets truncated. And that's, to me, really where our hypertension and pregnancy change package comes in. So if we could go to the next slide. As has been mentioned, this document was co-developed by my division, Heart Disease and Stroke Prevention, and the Division for Reproductive Health. And really that was to bring together our complementary skills and knowledge to tackle this cross-cutting topic. And then we had the tremendous privilege of co-authoring it with multiple clinical societies. I'm going to rattle these off quickly: American Academy of Family Physicians, American College of Nurse Midwives, ACOG, the American Academy of Osteopathic Obstetricians and Gynecologists, the American Medical Association, the National Association of Nurse Practitioners for Women's Health, and SMFM. The primary audience for this document is outpatient clinicians who care for pregnant and postpartum patients. Now, I will tell you, if you haven't looked at the change package yet, you can access it with the QR code or the URL on the slide, but it's a fairly hefty document. And the first half has some didactic information in it. It was sort of intended to be a one-stop shop for all things hypertension and pregnancy related. And then the second half is made up of tables like the ones that you see here with these colored headings, and I'll get to the meaning of those colored headings in just a second. But if you look at the column headers in gray, you can see the tables are comprised of change concepts. These are sort of just general notions for making change. They're sometimes known as key drivers in the quality improvement arena. Then we have change ideas, and these are the actionable implementation strategies. This, to me, that's where we need to be focusing. That's our sweet spot there. And then for each of those change ideas, we've gathered tested tools and resources from clinicians in the field and national organizations who focus on these topics. So again, you can access the change package, but I want to go through it just very quickly. Next slide. So the idea is that we have these evidence-based interventions for detecting and managing hypertension in pregnancy, including, and you could all probably just list these off the top of your head: appropriate antihypertensive medications, self-measured blood pressure monitoring or remote blood pressure monitoring, aspirin prophylaxis for preeclampsia prevention, shoring up transitions of care, etc. We use implementation strategies, or change ideas as we've labeled them in the change package, to support clinicians and patients in their ability to carry out those evidence-based interventions. So in these sorts of implementation strategies, they're cross-cutting and can be applied to lots of different topic areas. But they're things like having a clinical champion to spearhead this work and remove obstacles for the team, standardized treatment protocols or standing orders that decrease variability in care when the science is clear, using data to drive improvement through patient registries and clinician-specific feedback reports, lots of education and training for both clinical teams and patients, and then task sharing, also known as team-based care, which allows all members of the care team to work not only to the top of their license, but also the top of their ability. So we can go to the next slide. The color-coded headings I mentioned, they correspond to these focus areas here. So we have key foundations in red. These really include changes to policies and systems and the context of healthcare settings, including respectful and culturally safe care. In green, we've got equipping care teams. This includes providing supports for your staff to make this work easier. Population health management is in purple. These strategies affect sort of panels of patients and include techniques to find potentially undiagnosed hypertension and other gaps in care. And then lastly, we have individual patient supports in blue, which includes assessing and addressing the social drivers of health and other ways to set patients up for success. So let's just run through a very quick example using equipping care teams to show you how to use a change package. So let's say your quality improvement team decides it has a need to train care staff to interpret blood pressure measurement for better diagnosis of hypertension in pregnancy. We click once. The change package offers 2 change ideas. We've got providing training on those related clinical guidelines or using treatment algorithms to manage hypertension in pregnancy to really institutionalize that knowledge. If we click one more time, the team then decides they want to use those standardized treatment protocols to institutionalize the new guideline, and the change package then offers a number of different care pathways, algorithms, flowcharts. Insert your favorite term, but that's what we show. Lots of different tools that you can use as is or adapt to meet your needs in your particular setting. Now, for this action forum, we will be looking to many of you on this call to share your wisdom and experience making changes related to hypertension in pregnancy. And some of our presenters will inevitably do something very sophisticated and elegant analyses and quality improvement efforts. But I just want to be clear, quality improvement in this space, or really in general, doesn't have to be super sophisticated or a heavy lift. So just for example, if we can go to the next slide, accurate blood pressure readings are really the foundation of all this work, right? We're looking at hypertension in pregnancy. We want to ensure that the readings we're looking at are an accurate representation. And this is true whether it's in-office blood pressure measurement or self-measured blood pressure measurement. We included this infographic in the change package that highlights proper preparation and positioning for accurate blood pressure readings. Now, if the only place in your healthcare setting that a patient can have their blood pressure checked is sitting up on an examination table with their, legs dangling, back not supported, you might want to think about some office redesign strategies. For example, can you place a chair in every exam room so that patients can have their blood pressure taken sitting down? Can you invest in 1 or 2 of those mobile blood pressure carts that can be moved from room to room to room? That strategy isn't super sophisticated per se, but it can have a big impact on the overall accuracy of blood pressures that are taken in your healthcare setting. Next slide. So because the change package is quite large, we are working on digesting it into smaller bites. And if improving accuracy in your office blood pressure measurement is your goal, I've pulled out some of the pertinent change ideas. You can see the first one next to key foundations, that office redesign, right? We talked about that, but you could also take this a step further. You could train your staff on accurate blood pressure readings, or you could have someone physically assess staff adherence to proper technique, or you could implement a policy related to new hires and onboarding training requirements. There's really a variety of pathways that you could take to make change related to this particular topic, depending on the context of your healthcare setting. So think about, what are the barriers that you need to overcome to make these changes? What facilitators are in place to help with this work? And what is most feasible and acceptable for your clinical staff? This is where we want your brains at. So next slide. With that, I'm just going to wrap up, say thank you. I think we have time for questions, but others will correct me. And I know I have multiple co-authors on this call, including Sue, Lisa Ollier, Scott Hartman, Angela Lee, probably some others. So if you have questions, I'd love for them all to chime in and help answer. And please feel free to email me if I can ever be a resource. Thank you.
I've invited people to put their questions in the chat if they had any while you were talking, Hillary, just to kind of get things started. Or you're welcome to raise your hand if you have any questions. That was a really fast overview, kind of like speed dating, introducing all of the information. There is a comment that they would love good resources on accurate BP assessment of morbidly obese patients, something they struggle with inpatient. And there are questions about the sources for blood pressure cups if the person has no insurance. Does anyone have any comments on either of those questions?
You know, the blood pressure cuffs, if the person has no insurance, that is obviously a very tough one. We do have our partners at the American Medical Association have done a Medicaid analysis of self-measured blood pressure monitoring devices. So that's available. We can put that link in the chat. And oh, somebody already, Janet, thank you very much, already put the link in the chat. That's a great resource to just see what Medicaid looks like in a state. But this is an ongoing topic that comes up pretty much every time we talk about blood pressure or self-measured blood pressure monitoring. So we are acutely aware that it needs to be addressed.
And I think some of the information about accuracy of blood pressure monitoring and how to take a blood pressure accurately might be helpful in answering the question around blood pressures for morbidly obese patients. And I know that's something that we consider when we're doing some of the education programming as well. I see that Willie Spalding from the CDC has a hand up.
Yes, thank you. I appreciate that. Hillary, that was unbelievably wonderful. Thank you
Thanks,
for
Willie.
that presentation. I truly, truly appreciated it. And I just want to give you a quick heads up. I'm going to be sending you an email with a question just to you. But the reason my hand is up is because I'm hopeful that somebody on this call has a link to Alicia's video. If you have a link to it and could drop it in the chat, that would be so appreciated.
Yep, we'll get that to you, Willie, for sure. We're in the process of getting it up on the Million Hearts website, but I think we have a temporary link that we can share as well.
Thanks.
And I do see, Sue, there is a question from Annie Wagar. Sorry about that, Annie. Do you have a favorite published onboarding and yearly competencies tool and a competency tool for how to teach patients in SMBP technique? All tools related to those specific topics can absolutely be found in the change package. AMA, Target BP, they've got some really, really great resources that we've pulled out and carefully curated exactly for these topics. So if you sort of look up SMBP or accurate blood pressure training, just kind of do a Control F search, you should be able to find those tools real easily.
Yeah, and I noticed that Eleni also called out the Preeclampsia Foundation as a resource for some of this information as well. I think we might want to move on to some polling, and perhaps we can go through if we've missed any questions so that we can sort of circle back to that either in written communications or at our next meeting. So we have another poll for future sessions. We want to know from you, what would you like to hear about? Maybe not for our next session that'll be coming up in November, but for future planning, what are the things that are the most important to you all? If you can go ahead and take just a few seconds and answer this. And Taylor, I'll leave it to you when you feel like we have enough, if you can just bring the summary up.
I'm waiting until we get to at least 50%, and it's going up quickly. Thank you all so much for participating in the poll. All right, I'm going to go on ahead and launch the results. Please feel free to also share in the chat as well.
Okay, well, it looks like there are a lot of opportunities for information. Effectiveness of transitions in care. I think that was one of the things that really surprised us, how few tools and discussions there were around those transitions in care. So certainly something high on the list. Postpartum counseling on warning symptoms, which does kind of go with those transitions of care as well. Early identification of hypertension seemed to be rising to the top, as well as many of the things that you had questions on in terms of self-monitoring blood pressure, how to take an accurate blood pressure, et cetera. So thank you very much. This is going to be really helpful as we plan next steps. Now, we have one more poll, I believe. Here we are.
I'm bringing it up.
Now we want to hear from you and where your expertise lies. So which interventions do you have something that you can share with the group? And again, this will help us with future planning. And remember the importance of mentoring that I talked about as to the why we're doing all of this. And I should mention, you can check all that apply, so you don't have to pick your favorite.
I see the responses coming in. We'll give it about another 30 seconds or so, and then I will share the results. Okay, looking like the responses are showing now, so I'm going to share the results.
Great. Well, it looks like we have a lot of expertise in each area. Use of self-measured blood pressure, remote monitoring seems to be high on the list, as well as accurate blood pressure measurement, two things that have come up consistently throughout the day, as well as some of the other issues, effective transitions of care and so forth. So we will take this all into consideration as we plan. And let's move on to our next slide. So in terms of implementation, I'm going to turn this back over to Dr. Wright to sort of give us a summary of where we are with implementation and next steps.
Thank you so much, Sue. And I know this is true of all of you who have produced something that you think will help others in their work. There's definitely an achievement in producing the thing, but what makes a difference is implementing the thing. So we are very proud with all of our partners who have produced the change package, and now we are dead set on getting this thing implemented across the country. So committed to that we committed to CDC's director, Dr. Cohen, that by the end of this year, we would find at least 200 clinicians, those serving an outpatient setting, who are either implementing already or planning to implement, really committed to implement one or more of the strategies in the change package by the end of the year. TikTok. So we will have a mechanism so that if you are already implementing this and would like to be counted, we would love to count you in our 200, and hopefully we'll blow way past 200. But this is really just sort of starter dough or energy kindling, if you will, to get this thing flying off the shelves and into practice across the country. So we don't have our survey mechanism quite up and running yet, but we think we will in the next couple of weeks. As a follow-up to this call, we'll send it out. Again, I want to acknowledge that many of you have been in this space and have been implementing for some time. What we would love is to be able to highlight your work on future calls. We are all about scaling and spreading what works and lowering, as Tina Yarrington said, lowering the activation energy to getting these important strategies implemented. So please be looking for that strategy, or sorry, for that survey coming out in the follow-up materials. And we look forward to shining light on all of you at future action forums. Back to you, Sue.
Thank you. So just as we're closing, I'd really love to ask you to please put in the chat any links to any upcoming events related to hypertension and pregnancy that you think others might want to know about. And we promise to work really hard to make good use of your time on these calls. So we will take all of your feedback into consideration as we plan for November 13th. We really hope that we can keep these varied perspectives at the table and that we can support you as you expand and implement the good work that you're already doing in your clinical sites, your states, etc. If you would like to engage further with the initiative and with the teams that put this calls together, Taylor has graciously given you her email, and Taylor is absolutely fabulous to work with. We're going to follow up with a recording of this meeting, the implementation survey, and an email with a collection of all the links that were put into the chat today shortly. So we really hope that you will mark your calendar and join us on November 13th from 2 to 3 Eastern Time. And I just want to say in closing also, thank you to the CDC team who have been working tirelessly on this, everyone who's worked on it, from the Heart and Stroke team, from Millions Hearts, and from the Reproductive Health team have been fabulous and really put their heart and soul into this. So thank you for making it easy to bring this work to fruition. So thank you, everybody, for your time today.
Thank you.
Thank you all for your great participation.
Bye, everybody.
Bye.